selective in some of these, and feel free, if you see an assessment that you want us to cover, by all means, we will. However, otherwise, I'm gonna try and hone in on the most important. So we're gonna bypass the cervical spine, that's for a cervical course for the moment. Scapular mobility. So there's there's multiple planes that the scapular moves in, but particularly we care about posterior tipping and upward rotation. I shared before that I am a fan of numbers. It gives me confidence that I'm not being misguided emotionally or by the fallibility of my own biology. Yeah.
Oh, sorry.
Oh, sorry. There's just. Kobe, I'm going to borrow you. Do you mind slipping your shirt off for a second? And I'm just going to show how I, at times, quantify the scapular mobility. And I will have you kind of front and center here. So for those of you who have an Apple phone, I do believe you have a gyroscope built into the app. I'm not an Apple user, so I can't tell you how to navigate through it. People tell me that it's through your compass, maybe. I use an app called Clinometer. It's been influential for me. It's available on both Android and iOS devices. On the iOS device, I think it's like $1.99. Much cheaper than your goniometer, but there's going to be a question on your post surveys. No, I'm not making a plug for the app, it's just one that I like.
What is it called?
Clinometer. So it's like without the I and the N. Okay, Kobe, if you want to face that way. Okay. And then, so you're not in the light, maybe you come over to this way. Perfect. So, Kobe's a surfer, right, and a climber, and so he has pretty good development here. And so, what am I going to determine? I'm going to, we've already gone through our quantitative tests in our assessment where JC has already done his scapular assist test. We already know that this may be of utility within our treatment approach. All I'm trying to do is come in and instead of just saying, oh yeah, this makes it better when we work on your scapula, great. Are there impairments from side to side in regards to his scapular positioning, right? So, Midley, when you gave your example earlier, you did shout out a couple of normative values. We care less about what is statically, where can we rest statically necessarily, even though that can be somewhat important, but it's really more about how he moves dynamically. So what do? I palpate the medial border, and you saw me kind of dig my finger in, and so I start at the inferior border because it's pretty easy for me to get there, and I just kind of walk my fingers up just to the corner of the spine. That is the spine of the scapula. And then I bring my phone in, and I buttress that right up against it. And oftentimes I'll measure twice, just for confirmation. So right now he's downwardly rotated by 9 degrees on his left scapula. Then if I go ahead and ask Kobe to raise his arm overhead, if they have pain with that and they can't do it actively, then I will have him like hold on to something. Go ahead, Kobe, just hold that there. Again, I find the inferior border because it's a really nice bony prominence, and I'm like, if my classification for diagnosis is insufficient upward rotation, well, I better be able to quantify that and justify it, right? And he has 43 degrees of upward rotation from baseline, and then coming back down.
So this compass works just the same, you're saying?
Yeah, so what I was told is that if you swipe, you may actually get an inclinometer, so that...
It's measure.
Oh, measure.
Oh, it's under measure, not compass.
sorry.
Oh, measure, okay.
It kind of moves. I like that.
Okay, so in the frontal plane, that's how I quantify the scapular upward rotation.
So is that from -9, 43 degrees? Or
Yeah, so the next question is amplitude. Like, what is the amplitude? So he was downwardly rotated, and he went up to 43,
Okay.
right?
So
So
you're saying the whole-
he's 52
Yeah.
for his amplitude.
So are you documenting 52? You're documenting each?
Ideally, I'm documenting 9, or -9 and 43, and then if you have the ability to have like an Excel or qualification or calculation automatically, it would be 52. to, but for me, my system doesn't allow for that, so I write down all three. Yep. And I think I put I called it excursion, upward rotation excursion was how my terminology in the document. Alright, so I can quantify, the transverse plane doesn't really work very well, so I don't, for the internal and external rotation, I don't measure that. I potentially could, but right now I only, in my clinical device, I'm looking at upward and down rotation and how much posterior tilting he's getting. If you want to just face JC, whoop, I'm just gonna slide around and then take one step forward. And so once again, I'm still on anatomical landmark that I can be confident that I can come back to and get in future. And then if I was to be here, I would do it just like that. And again, where is my phone? It's this is the corner of his superior corner of his scapula, and then I would say you're at 18, 16, 15. Yeah, so 15 and a half, and then I would take it away, and I'd remeasure to check myself and make sure I'm consistent. Yeah. And I get referral, like we have a couple of docs who get really excited about altered scapular mechanics, and they say, they come in with anterior tilting. I'm like, great. I don't know how they do it, but that's how I do it, right? And then if you go ahead and lift your shoulder up once more, and again, he's a healthy specimen, so he can do it. And then he doesn't really change significantly. Oh, I'm sorry, he does change significantly because it went from anterior tilting to posterior tilting, total excursion of posterior tilting of almost 30, 32 degrees. Good? Yep, great. So where I'm not going to spend some time on is flexion and abduction. I'm going to assume that you guys are good with that. I think where I can add additional value is really in looking at the rotational capacity, which I said was like super important right before lunch. So that's what we will do. So Kobe's going to now transition to table, and then if you guys want to identify one of your persons at your table to be said patient. Again, I'm gonna, if you don't want to lie down just yet, so you can see me show it, but then I'm gonna show internal and external rotation, and then I'm gonna have you do it, and then we'll move into a different plane and do the same. So you're gonna need a couple of props. I told you about the said golf club or a cane or whatever you got. The second thing you're gonna need is a towel roll. I don't know where to find those.
On the carts in between the tables.
Here's one for you.
Thank you.
We'll take
Sorry, Tex.
Okay, so Kobe's gonna bend his knees and put his feet flat. I told you before that I'm a stickler about putting the constraints on the system prior to measuring, so we stick by that. The second thing that I do is, at least for this first internal and external rotation, I am about 30 degrees into abduction. And that's usually, for me, I either use their fist relative to mine, or I use my own fist. And depending on, again, it should be stratified to their own hand, but for all intents and purposes, it's about 4 inches of the distance between elbow versus the side of his torso. And then usually people don't know what I'm about to do, so I kind of help them out. I said, we're going to recruit your left hand, and we're going to go into shoulder external rotation as far as you can. A pro tip for you, Kobe, is once you hit about 45 degrees, you're going to want to lift up with your left hand so that you have a nice vector of force to consistently guide your hand down towards the floor. Consistently, what I get is that people go into elbow extension. Right? The other thing that I see is that people love to be in an elevated position with their rib cage. So I have them breath in, breath out, get rib cage down. Great. He settles the pelvis. And then Kobe, I'm going to have you drift off as far as you can to your right. Once they hit at least 45 degrees, that is my clearance that I'm going to also measure him in external rotation and abduction. If they don't have that, I usually find that the other one either be extremely limited and not worth checking or working on initially until this is established, and or painful. The phone, do you want to take it off your watch? I'm sorry for that. The corner of my phone is going to be right at the styloid, and it's going to rest on the bony prominence as best as I can on his forearm. The other thing that you'll notice that I've had him go into supination. His palm is facing up. That is also deliberate and consistent. It kind of pre-tensions them into external rotation. If they have biceps symptoms, then I will go like this and have them in more of a neutral grip, but I will never have them pronated, sorry. But until they tell me that they can't, I'm gonna go like this. And that's gonna pre-tension, as I mentioned, the anterior capsule, and like that. And so then my phone, right on the corner, like this. So those on the other side. Again, I always measure from the same direction, but just so you can get the concept, it's gonna look like that.
Would that be the same with the gluteometer?
What's that?
Wouldn't that measurement be the same with the gluteometer?
I would like to think that's the case, but human error, or at least my own human error, would would fail me because it's been determined upon the goniometer being absolute vertical. And so finding absolute vertical, now there's some fancy goniometers that have a little bubble in it and that can help you. I choose not to do it because I can very consistently and one-handedly just get this versus like fumbling with my, but you're correct, yes, that would be the traditional.
You use your own personal phone?
I do that.
And you can use an actual inclinometer too.
There might be some in the
Yeah.
other drawers in the, I didn't find one in that one, there was one here.
You just have to make sure you zero to from vertical for that one.
Calibration.
Yeah. Okay. Yeah. Calibrate from vertical.
And then internal rotation in this position. People are often actually surprisingly stiff. So I want to stabilize, but I don't want to alter his kinematics. So I'm going to gently come over top, but like as you can see, I'm not even blanching on my thumb, right? So it's relatively light, where I'm just kind of monitoring what's happening at the shoulder such that he doesn't lift off. I'm going to still remain in supination. I'm going to ask for permission to gently bring him into internal rotation. And then there's my R1, and it's not because of his belly, it's actually because of his shoulder. And you can kind of feel that because his belly is relatively soft, and I can kind of push into it, and it has a different tissue resistance. Eventually you're going to run out of room in a healthy shoulder, and there's not going to be much restriction there. Their liver is going to be the biggest constraint. And that's fine. And then I would do the same thing, so say he was restricted. I stabilize, but not aggressively. I push in. I say freeze. And then I do the same thing, same foam placement or goniometer placement. Again, I just find that I can stabilize. I don't have to do any of that. Yeah.
To put in a note for this, when you can let go of like your scap lock there, as long as you're keeping the arm stable. If the shoulder pops up, it's fine, but because you're keeping the actual like arm stable there. So like a lot of people like they might fumble around like, oh, I don't have an extra hand. Let go of like the scap lock, and then you can like grab your phone and keep your hand on. As long as you keep that hand on and holding, that's how you be like most consistent.
That's good.
For a bigger patient, would you bring the arm like more elevated?
I would,
like
very good.
snap?
Yeah, so I usually want the elbow to be resting in the bisection of the mid-axillary line. Yes. So the thickness of this is dependent on who you got on the table.
What
Very
about
good.
if they're very heavy and they cover their stomach?
Uh-huh.
You can't really get a true measurement.
Yep, that's true.
Okay.
And then are you looking for 45 degrees to internal? To
You-
go up to test here, or?
Yeah, so this one I don't have a limitation. It's usually just this one, as far as like my decision making if I'm gonna move up and do a new plane.
We want hand to belly though. Like you want to be able to actually make contact to
Okay.
that. Yeah. And that's
Without a restriction.
yeah, we're gonna go like later on. We have like key checkpoints,
Oh,
like
okay.
milestones, and that is one, a milestone.
Yeah, and what I've typically what I see is when patients come in and they're like, I can't get my hand behind my back. I'm like, yeah, I know. Right? Because as soon as you take up range of motion in one plane, the capsule winds up, just like the tissue of my shirt winds up, and it constrains other ranges of motion. And I tell them that that's a triplanar movement. I need extension, abduction, and then internal rotation. If you ain't got one of those, you're not going to have three. And I say, just be patient, kumbaya, trust in the process. If we get one of these at a time, I assure you that we won't have to do the towel behind back and crank your arm up there. All right, your turn. If you want to start standing with the scapular, you can.
You want to?
All right, again, these are going to be shorter breakouts. We're going to go for about 3 minutes.
Oh, also, we're gonna do one person do the measurement because we'll do different ranges of motion, so we'll switch for the higher one.